to mention and give credit to all the great people at the University of Pittsburgh and here at CORE that are part of this project. Abby Resnick, who is my project director, Kristen Lazara, who's a research assistant, Malia Himber, Mata Grozdan, one of my graduate students. Of course, we couldn't miss, I get to do these projects because I have a great partnership with CORE, and because Susan Stewart has a commitment to doing research and trying to work together to use research programs to inform what CORE does. Helen Bollinger, who some of you people might know, Misty Enos, who's the head of the outreach, and Shantae Wells, who's in charge of professional services, the hospital development work. Really great people. We're funded by a grant from the Division of Transplantation at Health Resources Services Administration. We just call it HRSA for short, which means nothing to anybody, but it's part of the Health and Human Services, Department of Health and Human Services. And it's the same part of the government that funds the organ procurement organizations and pays for transplantation, pays for UNOS. So they also have this grant-making mechanism. And Jim is #1 on our advisory committee, which is also made up of some doctors and other really great people from around Pennsylvania and West Virginia. So this is the research question. Will people be more likely to sign up to be an organ donor in their physician's office? And the question is really about people who are currently not registered. We're going to see if they indicate that they would like to discuss this topic with a physician in a clinical setting by giving them the chance to sign up to become an organ and tissue donor in that context. And we're also asking this process question, which is what is the best way to help physician offices implement donor cards? I gave you the rationale. The participants for this project basically going to be a random sample of approximately 90 primary care physicians' offices in West Virginia and Western Pennsylvania. We're going to recruit them and randomize them, and we're going to assign them to one of 3 research groups, which I'll describe in a couple moments. The participation for the doctor's offices is expected to last about 7 months, so about a month of baseline data collection, and then 6 months of actually implementing the project with some final follow-up after month 7. So we expect it to basically be for them to be able to get up to speed and do what we're asking them to do fairly quickly, and then have some results. It's a 3-year grant, so we're into year 1 already, so we need to get the results pretty quickly. So there are basically 2 interventions. There's 3 arms to the study. Stop me if you have any questions. If it sounds confusing, complicated, my language is shifting around, just say, hey, Howard, what are you talking about? And I'll stop.
Thank you, Howard.
So there's treatment A, which is what we call academic detailing. Treatment B is a web-based education program. And then the control group is just signage. So I'm going to explain it again and again and again. So the control condition is, here's the idea, that when public health agencies, organizations want doctors to do things that are feel-good things, that are public health things, but are things that are not necessarily going to be paid for or generate new revenue for the doctor, no matter how important they are, like smoking cessation or weight loss counseling or STD counseling or screening. If those things are not tied to a billing, an ability to bill, then there's just very, very small likelihood that it's going to get done, the doctor's office. So things like advanced directives and living wills, it just seems like the perfect place to have people make those decisions, to give patients the opportunity to talk to their doctors. And the sort of classic way that organizations and governments try to go about doing this is you make up a nice poster and some brochures, and you put them in the waiting room, and nothing happens. I mean, How many times have you picked up a really exciting brochure about what you need to know about diabetes, and then brought that right into your doctor? I just saw this fantastic brochure in your waiting room. I was bored to tears with the out-of-date magazines, and I started really going through those. It just doesn't happen. So that's our control group, because that's kind of how things take place. It's inexpensive, it's, and it's not very threatening, and that's going to be our comparison. But the active part of this project is we're stealing a page from the pharmaceutical companies. Now, I can't take credit for the theft. The original theft was done about 20 or 30 years ago, when some really, really sharp people at Harvard looked at what was going on in primary care. And the problems that they identified still exist today. There is, in general, overprescribing of medication. There is overprescribing of medication for conditions that are not the FDA-approved conditions, so off-label uses. There is excess use. Antibiotics are the easiest example to talk about. When people come in with a common cold and go to the doctor wants to be able to do something for them, so they prescribe an antibiotic when the cause of the cold is really viral. The antibiotic doesn't do anything at all. The underlying viruses typically go away on its own within several days. But doctors feel like they have to do something, and they give antibiotics. Same thing with pediatric ear infections, same exact situation. So now we got into that situation because the pharmaceutical companies send out really sharply dressed people out to the doctor's offices, and they bring food and they bring samples, and they talk about the new product and how it can be used, and they have giveaways and reminders, pads of paper and pens and all kinds of stuff, and it works. Now what these fellows up in Harvard discovered, Jerry Ahorn and Stephen Sumerai, what they discovered, and they did some research on this, and they surveyed doctors, and they found out that doctors who actually who say that they learn about new products from the pharmaceutical industry are more likely to be prescribing antibiotics for ear infections and common cold. Like the people who have their door open to the industry representatives are doing the worst job, and they have the worst knowledge base about pharmaceuticals. So what they did was they set about, yeah, exactly, go figure. So what they set about doing was coming up with a model to essentially counteract that messaging. And they called it counter-detailing, where they evolved to a term called academic detailing, where the idea would be to use the exact same strategy of going in person, doing a presentation, leaving gifts and samples and food and stuff like that. No, I don't think they give gifts and samples, but the same general MO, but then providing information about evidence-based best practices. And they showed that this works, that if you can get one-on-one or in person with the clinicians and give them the information that they need, that you can actually change that prescribing behavior. So there's been decades of work on this model, showing how it works and refining the techniques for doing it. What's interesting is that many hospitals and medical practices have started to disallow pharmaceutical reps from coming in because of the evidence that it is not necessarily leading to good quality, but also because it's creating conflicts of interest, which sometimes become quite significant for clinicians. So what we're doing. So in group 2, here we go. So it's group 2. We are calling it Treat a Day. It's just to make things complicated and confusing. So they're also going to get the sign in the brochure, because we're keeping that consistent across all 3 groups. And they're going to get this academic detail. And basically what that is 2 in-person visits several weeks apart from a trained person who's going to go in and talk to them about organ and tissue donation and work with them on introducing donor designation cards into their office workflow. And I think I'll have a chance to come back and talk a little bit. I'm going to talk a little bit more about what we're asking them to do when they go out there. But the basic idea is to go out, provide this education on site. Because one of the things that we have learned in doing this background research, preparing for this, is that organ and tissue donation is not covered in medical school. It's just not a topic, and certainly not the donation side. Transplantation is something that people learn about, but the whole donor donation process is not really part of medical school curriculum. And also for most doctors, especially in primary care, they're only, the chances that they're going to come into contact with donation and transplantation are if they have a personal connection, or if they have a patient who ends up being a donor or has a family member who becomes a donor and then they're being asked to give some advice. So it's actually, we think it's actually pretty rare, and there's some studies that show that it's actually pretty rare for doctors to have really been exposed to organ and tissue donation. And typically, as a consequence, they have the same misperceptions and knowledge gaps as the general public. The same can be said for the nurses and office staff who work in doctor's offices. Okay, now the thing about the academic detail is that it's expensive. I got to find the right person. Got to hire them. Got to train them, and then they've got to be scheduling these visits and going out to all these clinics and doing these presentations. And the problem with it is that it's a very hard work. You've got to get time. They've got to agree to give you the time. You've got to go out there, you're going to sit in the waiting room, they're going to cancel because their schedule's backed up. So you've got to come back the next day and be persistent. You're going to have to buy them lunches and feed the staff and do all kinds of hoo-ha to actually get access to the doctor's offices. Now, like I said, it's possible, it's popular, but it takes substantial amount of resources. So what we wanted to do was figure, well, what would be an alternative way of delivering the same information? Of course, we thought about using the internet. In fact, I'm not here right now. I'm actually an internet-based representation of how it. Anyway, so the idea is, what if we we take the exact same content, which will be accredited for continuing medical education, continuing nursing education. We put the exact same accredited course on a website so that the doctors and nurses and office staff can get the same exact content on their own time. So it's not competing with patient care, it's not taking their break, but they can do it in the evening, do it in little chunks, they can do it over the weekend, whatever, earn a free credit hour, which has some significant value to the professional staff. And then they would be essentially on their own to implement the workflow change. But it would be a lot less expensive to replicate and sustain if it works that way. So we want to try these two models of delivering the change head to head and see which one works better. Okay. So I will just go over this a little bit. So the idea here is that we're going to have staff from CORE and the University of Pittsburgh conduct these in-person trainings with physicians and staff on the organ tissue donation process. The idea here is this, and the original intuition was this, that OPOs like CORE, and I'm sure you guys, how many people are from this area? How many people from around the country? Local?
Well, that covers everybody.
Yeah, sorry. Let's see, and then outside of Western Pennsylvania. Okay, great. So all OPOs around the country have what's called hospital development. Are people familiar with that term? Okay. So the thinking here is, what if we took that same person who does hospital development, who has some clinical they might not have a clinical background, but they're working in a clinical environment. They really understand that, and they can talk the talk. And put them out in the community to essentially do the same kind of education in primary care doctor's offices. From the perspective of the OPO, it's sort of a reallocation of some of that staff time from the hospital out to the community. So that was the intuition around using hospital development staff in this way. In my travels now, I've learned that some other OPOs around the country are actually trying to do projects like this, actually using community outreach people instead of HD staff. And that perplexed me because I thought, well, you know, the community outreach people are really great. They can do a good presentation, but do they really have credibility in a clinical setting? That was the question that I had. But then I kind of thought about it and I said, you know, whatever works, works. Because it's a very different type of setting and getting access to that setting and actually setting up presentations and doing them might be more like community education than the professional education that hospital development staff do. So truthfully, I think it's an open question. I'm not sure we're going to be able to answer in this research what the best kind of staff person is, but we will hopefully know what the right content is to deliver. And then the question is, if another OPO wants to try it or if CORE wants to adopt it, then they're going to have to look at the content that we developed and actually see who's the best person, what's the best department in our organization to do this efficiently. Web-based training, which I referred to a little bit. The idea here is that, oh, sir, go ahead.
Your prior slide suggestion. You don't have to go back. Accredited for 2 hours. 2 is better than 1. Of free education.
It is free. It will be free. And actually, we're going to be, and I think I took this slide out. We actually have some financial incentives in the program because we need to collect some data from the doctors and the other office staff. So they'll actually, each person who participates can actually get about up to $100 for participating.
That's even better.
Yeah, it's even better, right? That tends to get people's attention. Although, one of the things
it makes them pay attention.
Yes. Now, one of the things that I kind of glossed over this, which is, what are we really expecting from these doctors' offices, and who are we expecting to really educate and train? So, in the idealized sense, we might imagine that this is an opportunity for the doctor and the patient to talk about organ and tissue donation and have a really informed conversation where patients can ask all different questions, where the doctor might initiate this topic with their patients, and then the patients can say, well, I'm not sure, you know, I have diabetes, can I really be a donor, etc. I'm starting with the premise that that's fiction, that that's just never going to happen. Because while we think it's a great idea, and while the people in this room, I'm sure, are committed and would love to have their doctors go out and do that, when we talk to doctors, they tell us, can I bill for it? And if they can't bill for it, they don't want to do it. And they already feel like they're pressed for time. They already feel like they're under substantial financial pressure. And if something doesn't increase their revenue, they don't want to do it. We always had from our get-go the notion that this is not really about the doctor per se. This is about the office. This is about everybody that the patient comes into contact with from the moment they walk through that door till the moment they leave. And the question here is this: who are they interacting with, and what do we really want to have happen? And I'll kind of get into this in a little bit more detail. But what we want to have happen is we want the opportunity to sign a donor card to be presented and be presented by, and don't take this the wrong way, by the lowest skill level person possible. In other words, we want it to be routine, and we want it to be presented in a routine way, in the manner that's most cost effective for the physician practice to implement. And then the role of the professional staff is now as moral leader and backup. So what we're asking them to do is to make signing a donor designation form a routine piece of paperwork that gets sent to court. And if patients have questions that they need to have answered, then the nurse or the doctor is there to answer those questions on the patient's initiation. So now what we're asking them to do is to be prepared to answer questions, not to initiate a conversation, but to support the process, support this whole workflow, and answer questions. Yes, sir.
Perhaps the form can be included in that clipboard of paperwork you get when we first walk into the office.
Yes. You want to come be a research assistant? You're right on track. That's exactly how we're going to set it up. So I'll get into that a little bit. Okay, so I described the poster, and we're basically using a standard donor card. I sometimes use the word donor card and donor designation form kind of interchangeably, but for the record, it's not a donor card. That is, the donor card specifically referred to the idea that you fill out a donor card and you put it in your wallet, and if God forbid you're in an accident, and your wallet is still in your pocket, then they can find out that you wanted to be a donor. That's not what we're talking about. We're talking about a donor designation form that people are asked to fill out, give back, and it's faxed over to CORE, and CORE puts your name in the donor designation registry, the online registry for Pennsylvania or West Virginia, and then the person gets an acknowledgement letter. So they are entered onto the registry. It's not just a card that they carry around, they're actually entered onto the registry. So we're calling that a donor designation form as opposed to a donor card, although we sometimes have the word donor card. That's not how we expect it to be used. This is what the poster is going to look like. We've drafted it up. I know it's kind of hard to see it in 2 dimensions here, but basically this is a brochure holder, and this is where brochures would kind of be slipped into here. And these are pictures of some either donor family or recipients from around CORE's DSA. And then we've got this really great quote: "Words cannot express how I felt knowing that my son was going to have a transplant, or how thankful we have been to the donor and her family. I'm amazed at how selfless a family can be in time of such tragedy." So actually we need to get the attribution for that. I think we have it. Okay, so to get into, we're doing okay on time. So here are the competencies that we expect from the clinician and the office staff. They should be able to answer questions, address concerns that patients might have about the organ and tissue donation process, be able to clarify misconceptions, be able to emphasize the need for organ and tissue donation to patients, and be able to introduce patients who want more information to Center for Organ Recovery and Education. We also have competencies for the front desk staff to provide willing patients with a means to register for organ and tissue donation, to be able to provide additional resources, and implement a procedure that integrates organ and tissue registration into their office workflow. I'm going to skip over this. So what we've done, where we are to date, is, well, we set out, okay, we've got this notion, we're going to have these people going out in person, doing education and training, and we're going to have a web-based course. So we need to have really rock-solid content for this presentation, because it's going to be accredited, because, and what we found is that it just doesn't exist. Like, there actually isn't a, I mean, there are textbooks on transplantation and so forth, but there really isn't a resource for primary care, that's aimed at primary care doctors that covers organ and tissue donation, the whole organ and tissue donation process. We were really surprised to find that, so we actually have had to create that. We've basically put together, with Jim's help, it's about a 30-page book or guide that actually has all this superb, up-to-date clinical information about about all of the different aspects of the organ and tissue donation and transplantation process. It covers identification and referral of donors. So that's the call on every death rules that hospitals face under their conditions of participation, declaration of death and brain death, and the distinction between brain death and persistent vegetative state. And we also cover DCD and donor management. What is donor management? How is authorization done? What does that mean? Organ recovery. We also cover allocation. These are all of the areas where misconceptions and misinformation are really out there. So what we've done is we've really put together something that I think is a really valuable resource. So we took that and just, as we started going, we started to put that into the presentation that the detail person would use out in the doctor's office, and it's basically an hour and a half worth of content. And back to your point, which was make it two credit hours, what we're concerned with is that actually getting 50 minutes of people's time is going to be very, very difficult. So
you don't have to fill the full 2 hours, After 35 years of continuing education in the legal field, they don't always go full-time. And the other thing that happened that I found very interesting was you had more and more attorneys presenting because it became a prestige item to say, I have presented this in front of this, and this. And the presentations got better over that period of time. And if you can make it an ethics requirement, it's even better.
Yeah, that's a good point.
There are no good ethics persons.
That's a good point. I will check into that, because so what we're doing is we're working with the University of Pittsburgh Center for Continuing Education and Health Sciences, so that it will have their, it'll come out
with their approval on it. That'd be great.
Approval. We didn't use the word ethics in our keywords, but we can loop back and check on that. I think that might add a little bit of cachet.
Well, the only reason I throw it in is that's one of the requirements you have to have. You have to have 2 hours of ethics in your biennial, review.
That's a really good point. Really good point. Okay, so let me keep moving, because I want to make sure that I don't go over time. So, okay, this is really the heart of what we want to have happen. So we've put together, this is a mock-up of an 8.5 by 11 sheet of paper. And this is what we want to be on the clipboard when a patient comes to check in for their visit. And basically, it's a one-page sheet. And what you have up here is, we've got these pictures of some donors and recipients. We've actually rearranged it a little bit, but this was the first version of it. The idea is up here, and it actually says patient visit information form instead of organ donation. And basically it says this: are you registered organ donor? Are you interested in learning how you can register to become an organ donor? And then the answer is yes, I would like to discuss with my physician at today's visit. No, I'm not interested. Then we've got some just basic statistical demographic questions. And then we actually have the donor designation form on this page. They could just, if they fill it out and they hand it back, they're done. If they have questions, then they don't have to fill it out. But what's going to happen is the clerk is now going to flag this patient for that conversation with the nurse or the doctor when they go back for their visit. We think the workflow, it's going to vary by office depending on patient volume. Some offices are big and busy and have electronic medical records. Some of them are paper and pencil. So we think that that's an area where that in-person visit is going to really help troubleshoot the implementation side of this. There needs to be a mechanism for alerting the physician when the patient has questions about organ and tissue donation, because we think, because it's possible that, well, the patient will remember because they've been activated, but if they get back into the exam room and now that they're to talk about their knee or their heart or whatever has brought them there for the visit, that it could be out of their mind. So if the form is there and the form follows the patient into the office, then there's a reminder, a visual reminder for the doctor and the patient to have this conversation. This just sort of goes over it in a little bit more detail, but basically what this says is, at check-in, you give them that donor questionnaire, should be printed on colored paper. Patient's going to fill it out, give it back to the staff. If they flag it, then they're going to go down this branch. If they don't flag it, then they've either signed the donor card or not. So either already a donor or they decline. For patients who want more information, then then the patient would take the exam, or the clerk is going to put it in the door bin, or however they do things, and then that's going to trigger the physician that this patient has some questions about that. Now, in some offices, it might be the nurse who has that question. Like after you do the check-in visit, then in bigger offices, you're then going to go and either a nurse or a medical technician or a medical assistant might do the blood pressure, height, and weight, and then go through some general health screening questions with you. And if they want that person to do the organ and tissue donation thing, that's great. I think that's perfect, and it'll probably be more likely to be successful than if it's left up to the physician. So we're open to working with them with whatever staff resources they have. The problem that we have is that we don't know what the resources are at the clinics until we actually go out there and say, hey, you guys want to be in the study, you agreed to be in the study, okay, what resources do you have? What's your staffing pattern? So we're thinking ahead to all of the variability that's out there. We don't know what we're going to find once we actually start, until we start actually doing it. Then the action step is to basically collect those forms, fax them back to core. That's basically all it takes for the staff. So we're trying to make it very, very easy for the staff to comply with this, to actually implement this workflow process. Of course, we have to do research. So we have to find out if it's going to work. So we've planned 2 waves of data collection. Baseline, after we recruit the physicians' offices, we have surveys for the physicians and all of the office staff. And then we're also going to be doing an anonymous patient survey. So we want to have some information about the patient population to find out, well, what's their baseline rate of being organ and tissue donors in that community. And then we also have some tracking systems built in order to track the implementation of the project. We're going to have we're going to ask the doctor's offices to send in basically a monthly status sheet, and that tells us basically where are they in terms of making this a routine part of their process. So that we think that's kind of an important reminder and what we call an implementation check. And then we'll also do some site visits. Yes?
Yeah, I'm hung up on the anonymous patient surveys.
Yeah.
I keep seeing HIPAA.
Yes.
So I don't know who his patients are, to give them a survey to see whether they filled out.
Well, so the design there is we're going to ask the front office staff to give patients surveys, to hand them out, and then we'll prepare surveys with envelopes so that it doesn't have any name or any other information on that survey. There'll be a tracking number per office, so we know which office it's coming from, but we're not taking any names, and then the patient will just stick it back in that envelope, seal it, hand it back to the clerk. Clerk just drops it in the mail and it's done. So they don't know who did a survey or not, basically. So it's not a HIPAA concern, and it's also not an IRB concern because it's anonymous. Okay, that was my last slide. Sir.
Howard, when you started your presentation, you indicated that 90% of people were in favor of organ donations, yet under 50% actually were registered. Is that something pertaining to the region you were looking at, or beyond that?
No, that's national.
That's national?
Data,
okay,
yeah.
I didn't know that.
Yeah, that number comes from Donate Life America. So they collect data on donor designation, donor registries from all around the country. And it really varies. Like Michigan was one of the worst for a long time, with something like 10 or 12% participation in the donor designation at the DMV. And the reason was because the clerks were not allowed to ask customers if they wanted to be designated on their driver's license. Now they changed that, and numbers went up pretty substantially. A lot of states like West Virginia are in the 30s, mid-30s. I think Colleen mentioned we just finished up a big project in the state of West Virginia, educating clerks about organ and tissue donation, and we were able to move that number from about 33% to about 36%. In Pennsylvania, I think it's really the high 40s, like 48%, but it really varies county by county. It's really interesting.
That is, where would one go to, get a flavor of how that is geographically?
There's a presentation in our presentation library that you want to watch.
Thank you.
Which was a presentation based on 2010 figures, which gets down for every state and all that detail. So you have it in your chapter already.
Oh, great. And you can also, if you can, Donate Life America puts out a report once a year that tracks this. It's called like their annual report card or something like that.
And that was John Green's presentation on that report, so you
yeah.
connected very nicely to it.
Yeah, that's
He's
fine.
the DLA, Donate Life America representative, and so I was right on. That's where it's from.
It's not always easy to find on their website, though. Sometimes you might have to like Google, use Google to find it on their website if you can.
And then you find, as he was just describing, variations based on state. As they collect that data, it's not necessarily accessible.
Right.
When they have a relationship with the OPO that's established by law to offer that information, for example, in Pennsylvania, the OPOs have access to that data by county. So when they're doing something, I'm talking about the eastern part of the state now, they're always tracking it by county, where they're in, what effect it's had, and they're looking at the county change. Mm-hmm. The city of Philadelphia, which is a county also, I guess, is the worst. And so there's a big focus in the OPO to change that number there as part of an overall program, using the DMVs and using that information.
They even break it down by zip codes within Philadelphia, so that when they look at things like putting advertisements on buses, they're looking at bus routes going through certain zip codes.
By contrast, in West Virginia, they just basically get a quarterly breakdown by age and gender. So, but very, very different. So every state is different. It kind of depends in part on what's in the enabling legislation, but it also depends on the sophistication of their data systems and various other things. Do you have a question?
Yeah, on the questionnaire that patients fill out when they come to the office, there's a yes/no question, and it's like, yes, and I would like to talk to the doctor, or no, I'm not interested. And I wonder if you might lose some potential feedback because the person might not feel like they have time, they might not actively want to talk to the doctor that day, or they might not have time or something, but they are interested. So I mean, maybe you architected it that way because you really need to know either on or off, yes or no.
Yeah. Well, I think that's a good point, and I think we'll find out. I think you're right. We'll, and actually the newer version of the form has slightly different wording, so I think you're right. I mean, the real goal is to flag people on that visit if they want to have a conversation. So it's designed to be a real practical thing. If we've now planted the seed and they're going to come back and they're going to bring it up at their next visit, then on their next visit they'll fill out the form and they'll check the box. Yeah.
So what if they already are organ donors?
So
what do they check off then?
The first one, it says, are you a registered organ
Oh, it
donor?
already says it.
Yeah.
Okay.
In back.
In Virginia, donor registration is by zip code. And what we've done in Fairfax County is we've looked at the U.S. Census data so that we can compare the percentage of donors by total population by zip code.
Right. So, yeah, that's a very good point. I kind of glossed over that. The Donate Life America report that I was referring to, they actually calculate it both ways, either as percentage of drivers, licensed drivers, or I think it's licensed driver or state ID holder, or as a percentage of adults living in the state based on the census data. The problem, I mean, neither one of those is
a perfect measure, because there are people who don't have a driver's license or state ID, as we're finding out, that they're not going to be able to vote because they don't have an ID, photo ID. And then using census as a problem has its limitations also, because it's only conducted every 10 years, and then the years in between the decennial census are basically a statistical adjustment to the every 10-year data. So and those statistical adjustments are always a little bit off. So if you're using as your denominator a number that's a little bit off, the more that gets off, the more your percentage is off. So neither one of those is a perfect measure of what's going on out there. So that's kind of challenging. Yeah, follow up, then there's no question.
But using the census data is more likely to pick up those that don't have driver's license.
Right, that's right. Did you have a question in the
I
middle?
thought I did, but I don't think I did.
Okay, I'll come back to you, and the blue. Then.
I'm not sure if this question was answered beforehand, but is this experiment being done in any specific kind of doctor offices? Like, is it just general physicians?
Sure.
Is it transplant centers? I was just curious.
Thank you for asking that, because I kind of went quickly over it. So the plan here was to go out to primary care offices out in the community. So we're looking at people who are family medicine, general internal medicine, general practice. We've kicked around whether or not to have an OBGYN, because there's a lot of women who use OBGYN as their primary care, but then we thought that we kind of went back and forth on that group. We wanted to get outside of the academic medical centers and hence the transplant centers. So we're trying to stay away from those practices that are really kind of part of the hospital. For the there's two basic reasons. One is we think that those people are probably already sensitized to these issues. That's one. Two, in a sense it would be too easy. In other words, it would be too easy for me to go down the hall or across the street to where I have a lot of colleagues and friends who work in primary care, and they're in the clinic that's at the hospital on the 9th floor. And they would do this. They would implement this because they like doing research, they're good partners, and they're good citizens for the research enterprise, and they would try it out, and then I could get the number, which is what percentage of patients are really interested in having this conversation. We don't know that number. We really just don't know. We don't know how effective it would be to get that answer. But it's not going to prove a whole heck of a lot, because it's only going to prove that when you ask your friend who's a doctor to go and do the thing, that they could do it. The real question is, can you go and do this in the community? Because that's where the vast majority of primary care takes place. And those are the doctors who are much, much less likely to come into contact with organ and tissue donation. The guys who work at a level 3 trauma and a transplant center, well, they've got a pretty good chance of coming into contact with all of these issues at some point in their career. Whereas the folks who are out in the community, the worst case scenario is that on the day that they've got a patient who is in the ICU and they have a family member saying, what should I do? What's the right decision here about donation? And the doctor has never had this experience before. And that's an unfortunate circumstance where sometimes that person makes a call that leads to not that patient not being a donor. Yeah. And part of the goal here is to sensitize the professionals about these issues. I've come out of time.
One more question, John?
Has anyone ever approached the legislature in any given state or the federal government to make organ donation mandatory from birth?
I've been working on that in New York State. That's never been accepted across the country.
Yeah.
And the chance of ever happening, given the democratic attitude is very slim. So it's a hot topic. That's not what we're talking about today.
Sorry.
I'm not going to get deep into it. Real
We
quick.
talked about it yesterday, you have problems in that donation is classed as a gift, and you've got 50 states, and you've got 50 gift statutes.
Yep.
And none of them are the same.
And some of them had, some things like, I can't reference the exact nomenclature here, have been standardized over a period of years. So it is possible to get states individually to adopt based on a template. And that's been done, for example, let me stop right there. I'm not sure what it is, but it has to do with declaration of death and stuff like that. And there is a general acceptance of that. So it's possible, long range coming, that issue, very hot issue. New York's passionate about it. Haven't been able to make progress with it. Let that one lie. Mary, one last question.
How does a doctor deal with a patient that thinks the doctor is targeted him for a special need for a transplant?
Need for a transplant?
Just bringing up the
Use it.
subject with
You're not talking about the local doctor's office talking to the patient. That's some different setting altogether.
You know what, I think you're onto something, which is, well, first of all, we're not asking doctors to bring this up with their patients. So if the doctor brought this up with a patient, you know, you could be an organ donor if you wanted to, or something like that. I think that would be, you know, that could go, you can imagine that going wrong, very wrong. So no, we're not planning to do that. And I didn't mention this before, but we're prepping some scripts and talking points to share with the doctors and office staff about ways to bring up this conversation. So what we're hoping to do is give them right information and the right way of talking about it. And what we are imagining, I mean, we can't control people. We don't know what they're going to say and what they're going to think. But what we are trying to do, what we think is the #1 barrier that is, well, I shouldn't say the #1 barrier. There's a really big barrier, which is people ruling themselves out. And we think that a lot of that is due to misinformation, because people don't think that they could be a donor because they're too old or their mother had cancer or something like that. And because of that, they never sign up and they don't really think it's for them. And we think that if they have the opportunity to ask that question and have their doctor say, well, you know, the fact is that that's a decision that's made by the transplant surgeons and the experts only after you die as to whether you're eligible to be a donor. So the best thing you can do is you can join the registry and tell your family that that's your wish. And then if you can be a donor, they'll make that decision after you die. So we're trying to script that out for doctors to talk to their patients so that they don't say the wrong thing. No.
Howard, thank you very much. That was
Thank you, Jim.
Great quotes from great leaders. You're certainly a great
Appreciate
leader
it.
in this area. And to point out, there's a DVD in the back. You can watch that on your computer.
Fantastic.
Okay.
Great, thank you very much.
Thank you.
Have a
Don't
good
forget
afternoon.
your lunch.
Thank you. I'll
And-
grab that.
And feel free to stay here just for a couple more minutes while we talk about our program.
Okay, great.
And the first thing I want to point out is TRIO has another program. It has nothing to do with what he just shared. However, in the sense that we've agreed, one, to give him level of support with the letter for the application, and secondly, not to do our program in his geographic area so that we don't skew his data. Okay, so the Pittsburgh people here, if you're around this general area, we're not asking you to participate in this. That's a real shame because you're here and you're hearing what he's doing. You may, through the OPO, participate in his program somehow, but we're not asking you to do what I'm about to talk about. Clear? We don't want to mess around. Now, in the future, as he gets further on in his research, that may open up. And we're talking about that, and like I said, I'm on his advisory board, so we're watching very closely and we're benefiting from some of the things he's developing. But our program is a little bit different. And first of all, his challenge is getting into the doctor and the doctor's office. And he's got a very complex process, well thought out, because he's a researcher and he's trying to find out what really works. Okay? We're not researching. We're not trying to be complex. We're going the exact opposite. We're going grassroots approach, simple. That's based on research we've done where several big organizations with major grants have gone out in the field and totally failed at trying to accomplish those goals. I think part of that is because of the complexity of what they tried to do. However, I'm no expert on this. I only know we're TRIO, and I think through our patient power, we can make a difference. We're not going to try and make a difference in every physician's office in the country. In your local area, do you have a physician you see or your family sees? Probably. You're going to get in to see the doctor on scheduled time. Because when you call to make an appointment, you're a paying patient. So you get right past all the roadblocks he has. You're not going to get there and they cancel your visit to educate the doctor because he's busy. You're going to wait like any other patient does for your scheduled visit. But when you get in there, all we're saying is, hey doc, you know me well. You know I've had a heart transplant. You know my history now for these past 18 years. Relationship, okay? He knows you, you're communicating that, you're passionate about something. Doc, just out of curiosity, do you ever talk to your patients about organ donation, just asking if they're an organ donor and if they need any information? The study that Howard was talking about is where this all started about 3 years ago. A researcher in Ohio put together a good study that ended up out in the literature, which talked about doctors agreeing this is a subject they should discuss. But only 17% of them ever do. And so that same doctor I finally found, I've been writing to him for years, he never responds. He's on the same advisory board, I finally got him. And so we're going to get closer to him. But that gave us the challenge. And so what we're doing is asking every TRIO member if they would, next time they see their doctor, your family has a relationship with you, have a transplant, you've got an excuse to bring up the subject. Just ask him that question. And based on his answer, we're going to give you two options. Okay? Basically, we're going to say, Doc, can I get you, and we may already have in your hand, a brochure that has answers to the common questions that you as a doctor probably are asking yourself, if you don't already know. Doctor says, I'm totally familiar with that, and yes, I'm comfortable talking to a patient. Oh, great. Anything you can do to help us, because it is a crisis in this country, we would appreciate it. Now, about my pain. That took 30 seconds. Okay? You didn't have to do anything special with your appointment to make that happen. We don't have any forms. We're not trying to get an intake into the package. We're just using you inside the office to talk to the number one guy. Now, they say no, fine. They say, yeah, I'd be interested in that. And let's face it, the doctor's got a relationship with people. He's probably going to say, well, yeah, I could use some help. Okay, great. Here's a brochure, a TRIO brochure that has that information that we may provide for you. Or I'll get a mailing to you. Would you mind if we put Donate Life brochures out in your waiting area? I like what they had there in terms of the brochure. And so we may try to piggyback on top of that, but our original approach just used the Donate Life America design stuff. And we have that in supply, and so you contact Sylvia. You have a postcard, you can do an email, you can call her. I think the call or email would be easiest. Basically say, I've contacted this office, they're not interested. I've contacted my doctor, Dr. Reel, I have a real doctor, Dr. Mark Reel, and he's open to this, so basically, please send, here's the address of the office, the doctor's name, their brochures, or, depending upon your situation, if you have a close relationship with that office, you want them sent to you so you can go back in the office and say, by the way, I'm putting these brochures out like the doctor said I could. Okay. Our follow-up, nowhere near this. We're not doing a research project. Okay? So what we're saying is the next time you have an appointment, are the brochures still there? Maybe not. Okay, Sylvia, could we send another set there? Or ask the doctor, by the way, doc, did those brochures come? And, oh yeah, people use them, whatever. Okay? That's it. Can you get any simpler than that? Using your personal life experience with the doctor you have a relationship with to just broach that topic and say, will you help us? That's what we're trying to do. Okay? Will that evolve over time into something a little bit more based on the experience that he has? I love his program. Personally, I think it's too complex. I think it parallels some of the other ones that have failed. The government's been behind a major grant, I think with UNOS. Could be wrong on that. And so every quarter they have to report back to the government the progress On the primary care physician program, I'm going to tell you, I've seen the reports for the past 3 years. Every quarter, there's a report that says, no change. Interesting, huh? On top of that, I found out that they developed some materials to help with this. And I said, great. Could you share the materials with us? Maybe we could benefit from it. Oh, sure. And so they sent me the postcard, which had on one side a recipe, and the other side, I don't even remember what was on the other side. I'm sorry. U.S. government, with all the money and everything, that's the best they came up with 3 or 4 years ago, and now there's been no change every quarter. You know, I think we can do better than that.
Back, I guess it was last April, during Organ Donation Awareness Month, Facebook did that thing where you could,
Yeah.
and they got, what, thousands of
Yes.
people?
Oh, it was
Yeah.
more
It
than
was like
thousands.
unbelievable.
Yeah.
Great.
And to me, that's like really easy. And
Yep.
But
There's a concept
it has
called-
nothing to do with being on the state register. That's
Well, I
just
thought
people
they
counting
could
their
register.
friends. You could if you went to another link.
Okay. But
Interesting enough, that concept, I would put in class something called nudge. We were talking to an advocate for this, and there's a book out called Nudge. And nudge uses the concept of not as formal as what we're talking about, a way of gently causing people to change their actions. A good example that stuck with me, and I have not read the book, but I love the concept. In Chicago, on the Riverside Drive there was a terrible curb. Accidents all the time. They tried everything. They put up signage. They put police cars out. They did everything. Didn't make a difference at all. Somebody who didn't know better came up with another idea. He says, if we paint lines across the road, and as we get close to that curve, we bring those lines closer together, people will think they're going faster, and they'll automatically slow down.
Yeah.
And they do. No sign saying slow down, it's just human nature. I'm looking for the nudge for our cause. That simple something that people will say, oh! I told the story last night? No, yesterday here. Remember the story about the father trying to make a decision about his wife's brain death decision for organ donation and the 2 daughters in? I mean, that little story, which takes about 60 seconds, is a nudge. Anybody hearing that says, well, if I could save lives, I certainly wouldn't bury it in the ground. Duh. You know, no facts or figures behind it, just changing people's attitude or action by nudging them. I'm looking for a better nudge for what we do. I had originally hoped to get this young man in here. He decided he wanted to make a difference in human slavery, bondage, whatever, in the world.
Trafficking.
Human trafficking, okay? And in college, he dropped out to go off and do something about human trafficking in the world. You've got to be kidding me. And you know what? He made a difference. He's brilliant. He's a great leader. He's an organizer. And he created a movement that really made a difference in that world. He contacted us because he was doing research on organ donation. And I thought, wow, what a great idea. Put him in touch with Walter Graham, for example, Howard Nathan, etc. People like that could make a difference, and he interviewed them. I haven't heard recently from him because he was applying for a grant or the position to work in the White House as one of those special young adults in the White House type situation, so his focus changed. Yes?
Well, I was wondering, based on that Facebook nudge, like how many...
That's an example of a nudge.
How many became actual registered donors?
No way
In
of knowing.
Pennsylvania, we had an issue because when you register, like, when you register, it allows you to go to another link that you can actually register on that site. With Pennsylvania, we had an issue with our DMV site, so other states such as California and others we saw thousands of registrations, hundreds of registrations, and unfortunately, I think in Pennsylvania, we probably only got close to 120 around there. So it was something that you needed to be a part of that movement at the time that it happened, when that ball was rolling. And unfortunately, if people did not want to refresh the link and try again, so we didn't get as many as we could, but across the United States, we did get a lot. Cool.
That's the challenge. I think of a covered everything here. Something that Howard said, for example, that I would give a counter to. He said, you know, we patients, we recipients don't have the credibility in, you know, those doctors' offices, etc. I would argue that's not true. I think we have more credibility. And a researcher maybe doesn't understand that or doesn't believe it because, you know, it's not what they do. I'm going to tell you that my wife and I every year teach 2 classes in medical school for medical students. And after one of those classes, they actually have, there's 2 different classes of people. There's 250 in one, and there's about 100 in the other each year. After the class, which we get 1 hour to present organ donation and transplantation, and it's always been come back as being very impactful, moving people. After one of those classes, they actually break out into workshops where they put the group of students, about 10, led by a doctor, through a simulation exercise of creating an organ donor process like UNOS, but for a fictitious world country. We've been sitting in on those, adding some reality to that. And most recently, the doctor who was supposed to do that wasn't available. There were 2 sessions back to back. And so the person who was the teacher in the class, the doctor there, sat in on the first session and let me lead it. And when he got through, he said, I don't have time to stay around the second session. You're doing just fine. Let me tell you something. I found out later that's totally illegal. I mean, it's a medical school. This is part of the workshop. And a non-certified doctor is teaching these students. That's what it comes down to. Yeah, I have an advantage. My background is in education, and my master's degree is in teaching, but that's not what they're allowed to do. But they do it. And I can't tell you how many of our speakers and as individual experience go into nursing classes, floor teams to share this. And I'm going to tell you, we got credibility. When we get through, the tears you can count the tears to see how credible it is. And I'm going to tell you, I don't care how good the paid professionals are coming in there giving that story, it's not the same as what you shared just the other day as an example of some of these stories and the heart you put into it. I'm sorry, they can't pay you enough to give that part of your life. Right, Ali? Yeah, and that's what makes the difference. And so the unpaid professional staff of these OPOs, which are also called volunteers, are credible, are capable, and I believe that our grassroots approach can make a difference. Am I going to do the research to count how many people register? I'm sorry, we're not that big. We don't have access to that. We're just going to go out there and make a difference. And so with that, we have 2 forms that Sylvia's going to bring up. We're going to take a break right after this, and then we're going to come back to the intimacy talk that's scheduled. But for right now, I just want to give you a heads up. Sylvia's coming around, and she will have 2 forms. One form is for those people who have indicated that they need scholarships up to $200 based on your expenses. We're not looking for receipts. You're going to fill it out down the bottom, you know, roughly what you pay for transportation, what you pay for lodging, and add it up. If it's $200 or less, just put the number there. Round off $200 is not a problem, and she will have the check later on today. All right. Secondly, and separate from that, is some way of supporting the primary care physician program I just described. If you're not involved with the scholarship, ask for this form. Very simply, it describes the process we talked about. And for those who want more details, this is what's up on our website. And this is a quick summary of what I just said. What we're looking for is people coming out of this 2-day workshop to say, Jim, I'll support it as best I can. That simply means when you leave here, you're going to share it with your chapter. You're going to talk to your family about this and see if they'll help. Secondly, your next scheduled appointment with your family doctor or any doctor you think fits the category, you're going to do your best to bring up the topic, like we just described. Okay? And based on whatever happens to that, you'll get in touch with Sylvia by postcard, email, or phone and say, could you help us send me the brochures to this office or send to me, I'll take it there. There's no follow-up to this. We're not going to ask you later, did you really do it? We know that if you sign this, you're just doing your best intention. So that's what it is, a way of saying, from our workshop, we got this kind of significant intention behind it. Simple as that. And so one form has both that and the scholarship application under it, and the second one is just the one form. So when she comes around during the break, ask for one or the other, and then at the end of the workshop, we'll have the checks available for you. Any questions about that? Simple, grassroots approach, best attempt, we're going to make a difference.